For newly diagnosed patients who are not transplant eligible, standards of care have been changing, and our standard of care, first of all, we take a patient and we risk stratify, whether they're standard risk or they're high risk. And as the clinical trials have shown us, triple therapy is still what's needed for these patients. So at our institution, these patients who would be considered standard risk would go on a treatment with daratumumab and lenalidomide and dexamethasone. For patients who are high risk, we would go to that traditional RVD light, so lenalidomide, bortezomib, dexamethasone at a lower dose, and then we dose adjust based on the comorbidities that they might have, and we can always go down on doses as they're in their therapy. For patients in relapse in that newly diagnosed non-transplant eligible, again, we're going to go back to risk stratification. So we're looking at those, if they have any high-risk features. We're also looking to see what other comorbidities they have or what side effects they may have experienced from their prior therapy. For that standard risk patient, now we want to go to a proteasome-based therapy. So we would go to something like carfilzomib and pomalidomide and dexamethasone at this point. For that high-risk patient who got RVD light up front, we would now go to something like daratumumab and pomalidomide and dexamethasone for those patients.
Oftentimes these patients start out as being transplant ineligible, but after a couple of cycles they will become transplant eligible. Their performance status may improve, renal function may improve, several other things may have changed. So we are also constantly reevaluating that transplant status, and if they are in their first relapse, then we may even consider doing transplant at that time.
That's a good point, Kathryn. We do constantly reassess our patients throughout, and I think one of the things we need to remember when we're thinking of transplant, it isn't just about age, it's about that performance status. So you might have a patient that comes in that they're younger and they could withstand transplant, but their performance status is poor. So if they work and as they're feeling better with therapy and getting stronger, sometimes we will go back in then and consider collecting stem cells and going ahead and taking them to transplant.
For our patients who are not eligible for transplant, our current standard of care would be RVD, so Revlimid, bortezomib, and dexamethasone for our standard or low-risk patients. And then now we're using carfilzomib, Revlimid, and dexamethasone for our high-risk patients. Just to kind of weigh in on the first relapse as well, at our institution, if they were not refractory or intolerant to Revlimid, then we were going to the daratumumab, Revlimid, dexamethasone as our kind of drugs of choice for that.